I have to ask, if they're so promising, right, if these drugs are so much better tolerated than the alternatives, if they offer so much more hope for actual cancer control than the alternatives, then why are we only looking at them for the second treatment that an incurable patient gets? Are there attempts to move these agents up earlier?
So when we develop new drugs, we always start with the sickest patients. But clearly these drugs have proven benefit, and they are moving into earlier lines. I still think this is only available as part of clinical trials. There's a number of trials looking at them in the first-line setting, meaning a step earlier. And there is actually, from other cancer types, data suggesting that they might actually work better because the immune system might be stronger. And so there are studies with similar agents, for example, Keynote-48 is a study with pembrolizumab, or the Kestrel study using an AstraZeneca compound, durvalumab and tremelimumab, or the Checkmate 651 study, trying to move these agents to the first-line setting. And I think that's exciting, and I think we likely will see that these agents will not just be used in the second-line setting, then in the first-line setting, but maybe even in the curative intent setting. So I think it's just a question of time, to answer your question, where these agents will be broadly used. It's a first step. The other thing I would like to point out is that it is a first step also in a sense that it's just a proof of principle. I think what we will see in the future, in the near future, and we're already starting to see trials looking at this, there will be combinations. We now know that the immune system can control cancer. It can potentially eradicate cancer. And PD-1 inhibitors are first step, but now we're already seeing maybe there are ways to make PD-1 stronger. Maybe you can add another agent, and I think at large centers, university centers, oftentimes these second generation immunotherapies, combination agents, combination trials are available. So I think it is an important thing to consider. PD-1 inhibitors will become broadly available, but there's already a second wave of agents being tested. So if you have the opportunity, I think it's worthwhile considering at least getting a second opinion.
Yeah, for people who can travel, I think there's a lot more travel going on for promising trials than historically in head and neck cancer. I think that's very well justified by the extraordinary promise of these agents. It's what I would do for myself or a family member, and I'm not going to nerd out on the science. I know you gentlemen would probably enjoy it very much, but I'm not going to nerd out on the science, but I think, I suspect we all agree that the next generation of in combination immuno-oncologic drugs coming out has extraordinary promise. And is worth, if it were a loved one of mine in the situation, I had the resources to get to a large academic center that had such trials, I think I would, and I would highly encourage those who are capable of it to at least find out what those options are and learn about them.
And I think that it's important for us to remember that, yes, these trials show a marked improvement in what we've seen in the past, but still, we're still around 20% of people who are responding. That's just not good enough. We want the needle to move further. That still means that 80% of people don't benefit, and we want to be able to help more people. So designing these studies with thought and care and viewing them from a scientific perspective, I think, is critical. So using things like biomarkers, which you've discussed, and understanding the nature of the tumors, things like targeting based upon human papillomavirus, or HPV, which is responsible for much of the cancers, the oropharynx, right in the back of the throat. And using that along with immunotherapy is another exciting option, but that's only one of the ideas that people around the country and around the world are considering.
I mean, I think immunotherapy is a wave that's going all across cancer. This is going to change how we treat cancer. And all we know right now is it can work, but we actually don't know how to best do it. And I think these kind of combination trials are going to explore better ways to do it, and that's why things are exciting. And I agree with you. If I had a choice, I would go for those combinations, especially because most of the time the side effect profile is beneficial. We don't know for sure that they're going to be better, but there's a good chance that we'll have several next generation immunotherapies coming. So it is an exciting time all across cancer, including head and neck cancer, because we have something that's new and it seems like it's working.